All right, welcome to the next part of labor and delivery, and it is the care of the family in labor and birth, part 2 of the PowerPoint. We're going to get a little bit more into the fetal monitoring side of things, okay? For those who may have never seen it, this is is this the old one?
Yeah.
Okay, this is, I think I did more editing in this one.
So I just take them out and...
Yeah, so there's some changes, even to some of the slides themselves,
Okay. I'll alter them.
yeah. So this is what the external fetal monitor looks like on a patient. Completely non-invasive. You don't have to be in labor or anything like that to be put on the fetal monitor. We are looking at the fetal heart rate and how well that's doing, and we'll get into some more details about that. And we'll look at some episodic and periodic changes in the heartbeat, which include accelerations and decelerations. So intermittent fetal monitoring is for the low-risk patient early in labor. Oftentimes the midwife patients, home deliveries, or otherwise in the hospital, low intervention type labors, they might practice intermittent fetal monitoring, where we are listening to the heartbeat for a period of time during and between contractions, as well as palpating contractions, but it's pretty low tech while still ensuring the health and safety of the baby. This is helpful when mom is up and walking a lot, in the shower, in the tub, things like that, where monitoring is not possible. Again, it requires a low-risk patient, though. If we're concerned at all about the health of the baby, we're not going to take the mom off a monitor and let them kind of roam free without knowing what's going on with the baby, because we have an obligation for the health and safety of both of our patients. Keep in mind that contractions, and I said this last night too, contractions constrict the blood flow, right? Because it squeezes the blood vessels. So in squeezing the blood vessels, it constricts the blood flow to the uterus, to the placenta, to the baby. Decreased blood flow to the baby means decreased oxygen to the baby. Normally, a baby with a good reserve can handle that. A baby who's already struggling with that oxygen supply will let us know that they don't particularly care for contractions by decreasing their heartbeat in a deceleration. Conversely, if I were to ask you when the best blood flow to the baby is, or when the best oxygenation to the baby is, it is when, between contractions, when there's complete relaxation. That's the optimal blood flow and oxygen to the baby. So, we definitely have guidelines in place regarding how often we have to monitor the patients based on their risk status, but also where they are in labor. As labor progresses, we're monitoring them a little bit more frequently. We are going to definitely get a fetal heart rate after rupture of membranes, whether artificial rupture of membranes or spontaneous rupture of membranes in the hallway or something along those lines. Before and after walking, before and after any medicine, oftentimes during medicine as well, at the peak of anesthesia, following or sometimes even during vaginal exam, certainly during or after any sort of elimination of bowels, urine, whether it's enema and catheter or spontaneous. Yeah, there's a lot of difference, to be honest with you.
I just missed it.
Oh, okay. So as I mentioned, it's completely non-invasive. We can do it even if they're not in labor, we can do it if there's not ruptured membranes, we can do it if the cervix isn't open. The nurse can do it without a doctor present, and it is part of the permanent record of the patient. Whether it's the piece of paper that comes out, and it's nowadays with centralized monitoring, it's in the computer forever. All right, so we're looking at fetal heart rate, we're looking at contraction pattern, we're looking at the fetal heart rate as it reacts to the contractions. As it is non-invasive, it's simply on the belly. The fetal heart rate uses ultrasound to actually get the fetal heart rate through the abdomen, and it certainly is affected by positioning. A lot of extra padding might make it a little bit more difficult. Positioning of both mom and baby. So if the baby is turned in a certain way, it's hard to get the baby's heartbeat. We go back to the way too many slides that I talked about where the baby was in the belly and where the best place to find the heart rate. This comes in handy when you're having a hard time picking up the heart rate. Do we have it in the best spot for it? Do we need to change? Because babies can move when they're in utero, so we just have to reevaluate. The other disadvantage, if you want to call it that, is that we're seeing contractions. We're seeing contractions begin, we're seeing them end, we're seeing how much time in between. But it's not at all a very good judge of how strong the contractions are. It's not a good measure of strength. Sometimes it's all about how tight the monitor is on the belly and how much padding is there or not there. It's not truly telling us how much pressure each contraction's creating. That requires an intrauterine pressure catheter, and it's an internal monitor. But here's your fetal heart rate. This is what it looks like. I guess you can't really see on the video here, but it's a big squiggly line. We like squiggly lines. In fact, the more squiggly, the better when it comes to looking at fetal heart rates. All right? This is different than like an adult EKG. This is not an EKG. This is a beat-to-beat record of the fetal heart rate. All right? Whereas one heartbeat produces all those different points on an EKG. This
would be like VFib.
Yeah,
This
this does
for
not look
life.
good. No, but yeah, in terms of fetal heart rate, this is actually very nice to see. I like to see just this, because every beat, every point on this is the heart rate at that time. Heart rate. So the more squiggly, the more variable the heart rate is, the healthier we believe the child is. All right?
What's the left side? I know that's the other side's the beats per minute. The other side is beats. Do you know?
Heart
I
rate.
don't know. It's metric.
Oh, yeah. Well, between 120 and 150, it's good, right? To beat on that
Yeah,
side.
maybe metric. I don't know.
That's normal.
That sounds like a good answer, though, doesn't it? There's no difference between metric beats per minute, but it's a good answer. I'm just going to stay with that. I don't know. But this over here,
Perfect.
beats per minute. So each of these squares is 10 beats per minute if you're going up, all right? 10 seconds going this way. Oops. So we move to the
That was the last side.
So a flat line would be less healthy for the baby.
flat line is still a heartbeat, unlike,
Well, not
right.
but less squiggly. Is
Right.
Less
So, but that's a good point. A flat line is still a heartbeat. It's just not very reactive. It's not doing what we want it to do, and we don't like it. So, labor and delivery nurses are highly trained and educated in interpreting this, because this is our patient, and this is the only thing we have, basically, to tell us how that patient is doing. Yet we are just as responsible for this patient as we are for the vessel, right? The mother who is able, we are able to touch, see, and talk to. This is all we have. So we are highly trained in interpreting those squiggly lines. So the first thing that we want to establish and assess is the variability. How squiggly is that line? And we just break it down into absent or undetectable, which is the flat line. Minimal, which is the squiggly is no more than 5 beats per minute. Moderate is from 6 to 25 beats per minute. Marked is above 25. Pictures, this is absent. There's no squiggle. And I know, I'll tell you a story about this a little bit later. I don't like this at all. I've seen
The
it.
beats per minute is,
Beats per minute, sure. It's about 120, 122. But it shows me that this baby is struggling and probably will not last long.
Was it sleeping though? What is
No,
it? I don't know what that
this baby is severely depleted oxygen-wise, has had too much hypoxia. This baby's sleeping, healthy but sleeping.
Okay.
Okay.
More squigglies. Okay.
Yep, it's just not moving around a lot. There's not a whole lot of activity. And they can have periods of minimal variability without any concern. We go through cycles, just you and I go through cycles of rest, relaxation, activity. This is a healthy baby who's simply resting. Perhaps.
Mhm.
The next 20 minutes or so, I'd like to see this baby. Same baby, just a little bit more active and alert, perhaps. Moderate variability. I like it, I like it, I like it. This baby has got a lot going on, lots of variability, lots of movement, and most likely is fine. But if we have a patient who maybe has a history of some illicit drug use, come in with a baby looking like this, I'm thinking this baby's feeling the effects of a hit. Is it a hit of cocaine? Right?
So he's hyper.
He's hyper. Not to say that every time you see this, worry about cocaine, but yes, it's fine to see it, but if it doesn't fit the rest of the picture, or it's like this too much, this baby's going to get really tired really quick.
so
And
moderate is
struggle.
what you
That's
do.
what-
Moderate, I like moderate. Moderate to me is kind of middle of the road. I'm not worried about a baby who's stressed, because sometimes a baby who's stressed but still doing okay looks like this too. So it's okay for periods of time, but if it continues and it doesn't fit the rest of the picture, then I get worried. But that's just from experience and paranoia.
So we monitor him for an hour.
It all depends on the risk category. It all depends on where they are in labor, and it all depends on perhaps the patient wishes and the doctor's preference.
Okay.
So that's variability, how squiggly the line is. Then we have episodic and periodic changes, and that's the accelerations and the decelerations. All right, episodic changes are not associated with contractions. So that could be your accelerations with fetal movement. That could be a couple of different, a different deceleration too, perhaps. What we call a variable deceleration, I'll show you that. Periodic changes occur with uterine contractions, right? So it's the contraction that's bringing on that change in the fetal heart rate. The fetal heart rate change, we are usually considering at this point are decelerations. And it can tell us a lot about the baby. So let's talk about episodic changes first. And yes, most often it's an acceleration. Got some fetal movement. We see the baby's heartbeat go up, stay up for a little bit, and then come back down. This is a good, healthy baby. I love to see this. This baby is neurologically intact, is moving, is reacting by increasing their heartbeat with that increased activity. This baby is healthy, and I like to see it. Like I said. That's what it said. All right. Then we have variable decelerations, which may or may not be associated with pushing. It could be positioning. Variable decelerations indicate umbilical cord compression. So somehow or another, it could be actually the baby squeezing its own cord. It could be the cord is pressed up against a bony prominence on the baby and pressing into the uterine wall. Or it could be during a contraction. It could be that there's not enough amniotic fluid cushioning the baby and the cord keeps getting squeezed with positioning and contractions. Could be because the cord is wrapped around the baby's neck, so it's easily compressed during pushing or contractions. But that's what it looks like. It's a jagged down and then back up again, all right, when the pressure releases from the cord. At this point, if this is like with every contraction, this patient looks like she's pushing, just by what I'm seeing down here. With every contraction, the heartbeat goes way down and then comes right back up. I know it's a cord. Somewhere there's a cord. I just want to make sure that the cord is not like hanging out of the vagina. So I still feel like this kid is giving me the signal that something is creating this deceleration, and it bothers the child. So I'm going to put oxygen on mom. I'm going to change mom's position, so maybe it is something just brushing up against. So if we can change the position and resolve this, great. So I'm going to do a vaginal exam too, just to see if I can feel like umbilical cord like coming down in front of the baby's head. That would be a prolapse cord, which is not a good situation at all. If it's really truly getting worse and worse as the contractions go on, I want to rest the baby. So I'm going to actually stop mom from pushing. I'm going to actually maybe even stop contractions. I'll give mom medicine to relax her uterus. Because as I said, a relaxed uterus increases oxygen. It is the most optimal oxygenation for the baby. And if the baby's just telling us, look, I need a little break, then we're going to give that baby that break. It doesn't mean this is usually a battle that we have between nursing and the medical world. Because as a nurse, not that I'm saying the doctors don't care. By no means am I saying that. I'm just saying that the doctor wants to deliver his or her patient. I have 2 patients that I'm concerned with, and the health and safety of both are my utmost concern. So if I'm inducing a patient with Pitocin and the patient is contracting away, and all of a sudden I see this, my other patient is saying, hey, I don't like this. So I might stop the Pitocin. I might relax the patient a little bit. Well, doctor comes in and says, what are you doing? I want to deliver my patient. The sooner we get this over with, the sooner your second patient will be with you. But it's that balance. So needless to say, sometimes we just need to give the baby a break, change the position, and then the baby can handle it.
So that's a nursing measure? As the OB nurse, you get to decide that?
Yeah, it's within the protocol.
I like it.
Yeah. The issue with stopping Pitocin is, it can also be a doctor's order, but within the order it says increase
Like
or decrease.
parameters,
Right.
AUC,
There's
AUC,
parameters. Right.
Yeah.
When you stop Pitocin, you have to start all over back at the beginning if it's been a certain amount of time. Sometimes they start at the halfway point, but you're going backwards in your Pitocin dosing. But
What would be the other medication that they would give to stop contractions?
good question. It's called a tocolytic, which means medication to relax the uterus. Terbutaline. Yeah. Terbutaline is the most common medication we would give to counteract or to minimize contractions. Because sometimes there is no Pitocin to turn off. She's in active labor on her own, and we still want to stop it to give baby a rest. So these are variable decelerations and what we would do about it. These are early decelerations. Definitely you can see that they kind of mirror the contraction. As the contraction goes up, the heart rate goes down. So we're mirroring. We got a little issue over here. You got it? You all set? Early deceleration mirrors a contraction. All right? Heartbeat goes down as the contraction goes up. As the contraction comes down, the heartbeat goes up. See what I'm saying? Mirroring the contraction. This one, I don't mind so much because this baby's telling me my head's getting squeezed. Well, if his or her head's getting squeezed, where are they?
Pelvis.
They're coming down. They're coming down and getting their head squeezed. So when I see this, I think, oh, this patient's going to deliver or is progressing in labor. Those epiduralized patients who are sleeping, we have them on the monitor or watching them on the central monitor, out cold sleeping, yet they continue contracting, which is a lovely situation. They're resting and everything. We're watching baby. Baby's doing well, and then all of a sudden we start seeing these early decelerations, thinking, and the baby is getting ready to come. That's when we might watch this for a period of time, and then wake the patient up, check her, and find out what's happening. Like maybe the baby's ready to be pushed out. It's great. So no interventions are necessary when we see early decelerations. Well, this is a late deceleration. And by gosh, if you're not really looking at the timing, it kind of looks like an early deceleration. It's a late deceleration because if you see here, the deceleration doesn't start going down until the peak of the contraction. So it doesn't exactly mirror the contraction. It's later. That's why we call it a late deceleration. All right? This, not only is that the difference between an early and a late, but the reason behind it is quite different. This is an ominous sign. This is telling me that there's a insufficiency with the uteroplacental blood flow, oxygenation to the baby. This baby says, you know what? I can't handle the stress of that contraction. I'm having a hard enough time on my own. And then you throw a contraction on, and I just can't handle it. All right? This baby needs help. So what am I going to do? I'm going to do what I did if we were having persistent and deep variable decelerations. I'm going to give the baby a break. I call it intrauterine resuscitation because I can't see that other patient. So I am going to oxygenate mom. So what blood is getting to that baby is going to be as oxygenated as it can be. I'm going to increase volume on mom so that maybe if she has just a slight decrease in volume, dehydration, anything, we're going to increase and provide her with the optimal amount of volume so that maybe more will get to the baby. I'm going to turn mom, which is the easiest and probably first thing we should do, is turn mom, change position. Left lateral position is the ideal position for blood flow to the placenta, to the uterus for some reason. So anatomically, for some reason, that's
Turn it where?
left lateral on mom's left side. However, if it's a cord issue, that might not. We will naturally go to the left side first, but baby might say, "Oh no, thank you," and you're flipping you have to find the right position for the baby. But generally, we will start with left lateral because that is been shown to have the best blood flow to the uterus. We're going to stop the stress. We're going to stop the contractions. That's intrauterine resuscitation. And we will do that for a baby like this. The issue is, the contractions are progressing labor so that we can get this baby born. But if the baby says, I don't like this, you stop everything. But that's not getting the baby born any quicker. It's this balance between, sometimes the baby just needs a break. So we'll do this whole intrauterine resuscitation, give the baby a break, and then bring the contractions on again. And we'll see. Maybe we can progress further in labor that way. Or maybe it's time to, fish or cut bait? Is that what the expression is? maybe it's time to say, we have to get this baby by another means. Intrauterine resuscitate the baby and prepare for a cesarean section because the baby can't handle the stress. Make sense? Sure, right? It's a balance to protect both patients. As I mentioned, that's what we do. Certainly notifying the provider is on the list as well. So there's 3 different kinds of decelerations. And each one means something different. We have the variable deceleration, which is the cord compression. We have the early deceleration, which is the head compression. And we have the late deceleration, which is the placenta issue. All right? And this kind of is a nice chart to kind of go through and what it's describing it and what it means. This here is a nice way to remember what each of them means. Veal chop. All right? And hopefully this doesn't ruin veal chop for you, although I don't eat veal anyways. Veal chop. V means variable. You match that up with the C of cord compression. Early is head compression. That's not in there, probably. If you have an old PowerPoint, this is new. A is acceleration, which is the other change that we talked about. And that's okay. That's good. A-okay. L is late, and it's placental insufficiency. All right? So that's just veal chop. If you remember veal chop and they match up, then you'll remember what each of those changes, fetal heart rate changes, and what they mean. Then you have fetal bradycardia. Well, fetal bradycardia is just like bradycardia with us, all right? Decrease below the baseline for an extended period of time. 10 minutes we're never going to wait a whole 10 minutes before we call it bradycardia. We're going to start doing all this intrauterine resuscitation, all right? Bradycardia is telling the baby's saying, I told you I didn't like this. I told you I didn't like this. Now I'm telling you, this is what's happening. Boom, down it goes and stays down. And then we try to bring it back up by doing all that stuff. Just like we talked about earlier with an epidural and the hypotension, the resulting hypotension, this baby will also, maternal hypotension is one of the reasons why you'd see fetal bradycardia. Mom's blood supply just isn't getting anywhere. It's not getting to mom's head, not getting to the baby's placenta. So it'll tell us that way. Sometimes with a bradycardia, if we can't figure out why, mom's blood pressure is okay, and all of a sudden this happens. Maybe there is she breaks her water, and remember I told you we have to check the fetal heart rate after the water breaks. Well, maybe the water breaks and we're checking the heartbeat, and it's bradycardia. Well, I'd check because I bet you the umbilical cord has come down and is now being completely and permanently compressed, leading to a bradycardia. Fetal tachycardia. You think, well, that's better than bradycardia, right? Not really. That baby's simply quite stressed and will get tired real soon. Fetal tachycardia could mean mom has a fever, which means if mom has a fever, maybe mom has an infection. And if mom has an infection, it's most likely in her chorioamnion, in the uterus somewhere, which means baby has an infection. It could be that mom's dehydrated, therefore baby's dehydrated. It could mean that the baby is anemic. So just all the reasons why our heartbeat might be elevated, so that is the truth with a baby as well. All right, maybe mom's doing some drugs, and her baby's heartbeat are elevated. So we're gonna try to treat the source. If mom has a fever, and we're concerned about infection, we're gonna give Tylenol. We're gonna give antibiotics. If mom appears dehydrated with other symptoms like concentrated urine and not good rebound, then we will Give fluids. Yeah, so sometimes we can fix this on, fairly easily, yet we have the underlying issue, especially with the infection we're really concerned about. We had a patient the other night who was delivering. She was pushing finally after 2 days of attempting to have her baby, finally having the baby, and that baby's heartbeat was almost 200. Yeah, we didn't like that too much. Pediatrics was called to the delivery, and they ruled out infection by doing blood cultures and stuff on the baby afterwards. But the baby appeared fine, probably just very happy to be out. I don't know. I mean, that was I'll find they're gone by the time I get back there tomorrow, so I don't know. Anyways, everyone did fine, but it could just been a baby pretty excited to meet his parents. I don't know. Nonetheless, we treat the problem and hopefully fix the problem. So we got a baby who's chugging along, real squiggly line, variability is really great. All of a sudden, what's that about? Like all of a sudden, it could be, but most likely, maybe we gave mom some meds, right? Maybe we gave mom some of that Demerol or that Fetal, and the baby says, thank you, and kind of chills out too, all right? Maybe it is just fetal sleep cycle. I mean, if we see really squiggly lines and we see decreased squiggly, and 20, 30 minutes go by, and when we see the squiggly again, we know the baby was just taking a nap. That's okay. The issue is the balance between, okay, maybe this is okay, maybe it's not. And how long do we go and wait before we follow up? If there's no obvious, sometimes it's like, well, I just gave mom some Fetal. Apparently the Fetal has now crossed the placenta. My first reaction when I see the decrease in variability, when it was fine before and there hasn't been any interventions or occurrences, is that the baby's just sleeping. So I'm going to sit and I'm going to watch this for 20 or 30 minutes, provided there are no other like decelerations or anything like that. And after half an hour or so, I'll be like, okay, let's wake this kid up. Let's get this kid going because I don't want to watch that anymore. This might be when we do a vaginal exam, and I call it scalp, not just me, we call it scalp stimulation, where for 15 seconds or less, we actually rub the baby's scalp. Yeah, doing a vaginal exam, we get up there, or wherever we can find the opening, and we literally rub the scalp on the baby. That wakes him up. If that's what the problem is, that's going to tell him. If you rub it for more than 15 seconds, it might actually stimulate the vasovagal, and there's trouble. So you don't want to do it for more than 15 seconds. And if they're going to wake up, they're going to wake up with that. Yeah, exactly. We can't reach the sternum. And then we'll do the position change. We'll do all those things. Sometimes we just have to make sure this kid is okay. We're going to do all these non-invasive things first. Otherwise, if we have ruptured membranes and we have a slight opening with the cervix, we might put on a fetal scalp electrode, which is literally, the little spiral coil in your clicky pens? Mm-hmm. So it looks like that, not nearly as coiled. A couple of coils of that, much, much thinner. We literally screw it into the scalp of the baby's head. You think, what? So they come out with like a little scratch. It's not a deep screwing in of this thing, anything. It's literally just under the scalp. And it's a great, great, very, very specific measurement of the fetal heart rate. So we might have to do that, just to make sure everything's fine on the kid. All right? The other internal monitoring that we might do is called intrauterine pressure catheter. Again, we need rupture membranes. In order to get into the baby and put the intrauterine pressure catheter, we need to get in to where the baby and the pressure is coming from, and that is inside the amniotic sac. So the amniotic sac needs to be busted. It needs to be open. So rupture of membranes is the key in order to use internal monitoring. They need to be slightly open, but you can fit both of these things into a pretty small space. So there's no dilation. They don't need to be 8 centimeters dilated in order to do it, okay? So fetal scalp electrode, pretty simple little, thing on the baby. The intrauterine pressure catheter is a longer catheter that we actually thread into the cervix and then up and around the baby a little bit, into the uterus. This is the only specific and exact measurement of the strength of a contraction. This is going to tell us how strong the contraction is in terms of millimeters of mercury pressure. It's going to tell us if the contraction is truly relaxed between contractions. It's going to tell us a lot. Right? Why then do we need that? Well, sometimes a patient, contractions aren't picking up very well at all. Maybe she's very heavy, there's a lot of padding, and we just can't palpate the contractions the way we want on the outside. But she reports being very, very uncomfortable. And she's wanting pain medication. She's wanting, we need to know if she's having contractions. And we can't tell by the outside. So we might put this in to find out, oh, indeed she is having adequate contractions. And they're strong. It's not as much about pain medicine as is the labor progressing, all right? If we're giving a patient Pitocin and we are inducing contractions, we have our guidelines. We can't have a contraction last more than a minute or minute and 15 seconds. We cannot have a contraction closer than every 2 minutes. We cannot have a contraction too strong, to this, that, and we cannot increase the Pitocin if what we're seeing is contractions a minute long every 2 minutes. Well, if mom doesn't appear to be all that uncomfortable and we're not really going anywhere, they might look pretty impressive on the external monitor, but they're piddly little contractions. So we might put an intrauterine pressure catheter in, and that gives us one more thing to help us make decisions on the use of Pitocin.
So that's how Pitocin is judged, is the IU.
IUPC will give us another thing to judge it by, all right? Because an external monitor is showing us the contractions are lasting a minute and they're every 2 minutes. So we're not going to increase the Pitocin if that's the case. All we need to know is that the contraction strength is well under what we would want it. And then we are able to increase Pitocin so that we can increase the strength of the contractions. So intrauterine pressure catheter can help with that. The other thing the intrauterine pressure catheter can do is it's a two-way system. So if a baby is having persistent variable decelerations and it's very obvious that there's not a whole lot of padding around the baby, maybe mom had oligohydramnios, which is too little amniotic fluid, and she's broken her water, so what little amniotic fluid she had is dripping out of her. And baby is just getting too squeezed. The cord is getting too squeezed and they don't appreciate the contractions. So we might actually infuse up to 500 milliliters of warm saline into the uterus to mimic amniotic fluid to kind of cushion the baby, cushion the cord so that maybe they could tolerate the contractions. You're doing it in as sterile fashion as possible.
You said it's normal saline?
Normal saline. Sometimes ringers lactate. It doesn't usually matter, but we want it warmed. So there's risks involved with that in terms of, infection and some other risks. I don't see it done really, really frequently, but it certainly is something that can help the woman progress in labor and deliver her baby vaginally, when they might otherwise say, we can't do this anymore. We can't watch this kid suffer like this anymore. So, I mean, it certainly has its advantages and a good option for a baby who needs a little cushion. I talked about the scalp stimulation test there already. Rub the kid's head. Just a quick bit about categories of fetal heart rate interpretation. You're not that's not on here. It's back in there. I switched things around. Just to let you know, there are 3 different categories in our fetal heart rate interpretation. Category 1 is good. Category 2 is concerning. We're going to do some interventions. We're going to try to figure out things. Category 3 is ominous. We know it's not good. Category 2 still has some question like, well, maybe if we just change mom position, give her some IV fluids, it might be okay. Category 1 is just fine, and these are the components of it. Category 2, I'm going to watch a little bit more. I'm going to start doing some things, all right? Category 2 continues with, Category 2 is probably the most common issue. Category 3, not good, all right? Not good at all. This is not good, all right? This is called sinusoidal fetal heart rate pattern. Not good.
So would they do a C-section then, like, immediately, or?
This baby's probably already too far gone.
Oh,
This baby has chronic asphyxia and anemia. I had a patient who I learned a lot from. I still remember her name, and it was 26 years ago. She came to us because she hadn't felt her baby move. The doctor's office was closing. She came straight from work. She worked in a local grocery store because I remember the shirt she had on. Had her name on it on one side and the grocery store logo on the other. So she came to us. I put her on the monitor, and I saw a bunch of stuff that I did not like. I saw a little bit of this. I saw some late decelerations because she was having some contractions. I saw everything that I learned about that was ominous. There it was, right in front of me. It was subtle, but I was smart, and I recognized it. So I went to the doctor. This was back before it was all computerized. And maternal fetal medicine was over an hour away. So we would oftentimes fax the paper strip to maternal fetal medicine for their opinion. But you needed a doctor's order to transmit the strip, as we called it. So I approached the doctor and said, I'd like to transmit the strip because I'm seeing this, and I'm seeing this, and I'm seeing this. This being one of the things I was seeing. You nurses are always looking for trouble. You are overreacting. We just need to get this patient delivered. So I took that little bit. Conveniently forgot that he told me not to and transmitted the strip anyways. So he was coming down the hall, and I said, I'm sorry to tell you, I'm transmitting the strip anyways. Would you speak with the maternal fetal medicine doctor when they call? And as we were in the hallway talking like this, maternal fetal medicine was calling saying, get this patient delivered, and I lost my heartbeat on the baby.
oh.
So I went in and I started doing all those things that I was taught to do. Left lateral, oxygen, IV fluids increased, do all of these things. But it was too late. So the baby died in my hands, basically, around her belly. So it was pretty devastating to everyone.
What was a full-time baby?
Full term. We rushed her back to the C-section room. but it was too late. So we're not going to do a C-section for a dead baby.
As a deliverer?
She had to deliver the baby. So the whole time she was all by herself. That's, I think, was one of the things that struck me, is that she handled all of this completely alone. So it was pretty tough. And I got to tell you, that doctor was the most devastated out of the medical professionals. That doctor was pathetically weeping. And I was a little pissed off. But I was respectful. And of course you feel like it's your fault. Looking back, very shortly thereafter, this child was too far gone before it even arrived on our unit, based on what we saw. If the child was born alive, it probably wouldn't have lived long. But it was still alive when it got there, and not shortly thereafter. So we had a moment, more than a moment. I sat down with some more senior nurses who were the ones who were guiding me through this whole assertiveness, and they were making sure my documentation was where it was supposed to be. In the meantime, they canceled the C-section, and they were bringing the patient. They brought the patient back, and the patient is all by herself, knowing her baby was dead, in the room. 3402 was the room number, and there I sat, the doctor weeping in the corner. It was pathetic. It was a very pathetic scene. He recovered enough to say, well, I guess we need to induce, now we need to start Pitocin and induce the patient. And I'm like, whew. And then I look and everyone's looking at me. And I'm like, oh my gosh. I have to do that. I have to walk back into that room? Woof. So I'm like, oh my gosh. So I start heading down the hall like, I don't want to go back into that room. It was my hands on her belly when that baby died. I was the one who couldn't save her baby, like, whew. I got halfway down and the doctor grabbed me, I'm sorry, and I just backed off, just from now on, believe me when I tell you what I think and what I'm doing. Just believe me. And we had a very good relationship, and I respect him greatly, and he respects me. Anyways, so it was the hardest thing to do was walk back into that room, because I wouldn't blame her if she told me to screw off and leave, I remember standing outside the room like, okay. Knock, knock, knock. Hey there. And I walk in, knowing she was in there all by herself, knowing somebody had to be in there, but was I the right person? I'm not so sure. So I peeked my head around the curtain, fully prepared to receive my marching orders. When she looks up and she goes, oh, thank God you're back. So you make an impression on your patients, even if you don't think it's the impression you actually do. So I stayed well past my shift to deliver her baby, who was wrapped many, many times with the umbilical cord. It was the longest umbilical cord I've ever seen. It was wrapped 5 times around the baby's neck and about 7 times around the baby's body. So this baby was just rolling and just making it tighter and tighter and tighter. And I remember feeling her belly. It was almost like a bowl in her, and it was probably that last movement that just completely cut everything off. So that's the reason why. So that doctor was the deliverer, so it was the silent delivery room. And to this day, I was the only one there for that patient. I don't know where everyone else was. It was not like it was days and days worth of time. Mm-hmm. It was a shift and then some, a little bit, but nobody was there for her, which was sad. So it was a silent delivery room. no fetal heart rate, but boom, 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 you know. And out comes the beautiful baby boy, dead. And when he's unwrapping the baby's umbilical cord, going, I'm sorry, I'm so sorry, I'm sorry, I'm so sorry. Oh gosh, I'll never forget it clearly. But what it tells, it should tell all of you is that you got to protect your patients. Now, there was nothing I could have done to really, truly protect that baby. That baby was already, I know, too far gone by the time it was telling me that he was in trouble. But you mean more to your patients than you know, and you have an obligation to not only protect your patients as best you can, but to be there for them in their time of need. So, and that everyone is human, and that however you behave, it should be respectful, no matter what. Sometimes you need to push a little bit to assert and advocate for your patient, but no amount of rude, non-professional behavior is called for in any situation. So it also tells you you better know what you're doing. You know, take your continuing education, take your required classes and tests that you have to take. You think NCLEX is the last test you're taking? Absolutely not. If you want to be at the top of your game, if you will, as a nurse, there's a whole lot more to learn within your chosen and specific path. And that's the other side of OB, which people don't like to think about. And I apologize if I'm upsetting anybody with that story. But it's an important one because that baby was telling us, you know.
Is there any way to avoid the cords being wrapped around? That's just something that,
Yeah.
just because of the way it is?
Yeah, and unfortunately, I mean, this was extremely long umbilical cord, which was in itself very, very uncommon. But sometimes an ultrasound tech will say, ooh, I see a nuchal cord. Nuchal cord is the cord wrapped around the baby's neck. Oh, why are you telling the mother that the cord is wrapped around the baby's neck? Because we might have another month and a half before this baby's born, and there ain't nothing we can do about it. It doesn't mean that there's anything wrong. So for a month and a half, they worry about a cord wrapped around the baby's neck. And sometimes you really can't tell, on ultrasound. So
if they
there's
can't,
nothing we
would they,
can.
would that be somebody that they would deliver early then?
Mm-mm.
They just let it go?
Yeah, I mean, the baby will tell us.
Yeah.
Oh, okay.
The baby will tell us if they can handle the squeeze. There's two things: nuchal cord and a true knot. A knot, like, I don't know how it happens, but the baby's twisting and turning when there's a whole lot more room in there. It actually creates a knot in the cord. Well, a true knot it's a knot, and like you would rope it on a rope. And that's been, if the knot gets pulled tight, that has been enough to kill a baby. In fact, babies who look perfectly normal, there's no other explanation for the intrauterine fetal demise. When the placenta and the rest of the umbilical cord comes out, there it is a knot that just got too tight. I don't see that often, but when I see it, that's the explanation. Weekly, we see cords wrapped around the baby's neck that aren't tight and can be reduced, and
The babies don't breathe, so, I mean, they get all their oxygen.
through the cord.
Yeah.
So if the cord is wrapped,
Well, if the cord gets compressed, right, but it's actually not.
that's
the
what
neck.
it's about, is a
Okay.
cord getting compressed.
Right.
Yeah, not
neck,
the, right,
neck getting compressed.
right. So the intrauterine fetal monitoring and the intrauterine pressure catheter are certainly great. There's your picture of those things that for people who might need it. I kind of already talked about disadvantages and advantages. Increased risk of infection, sure. Increased chance that the pressure catheter that you're putting up there gets pokes through the placenta or just something damaging to the, pokes right through the uterus. I mean, all sorts of things that I guess could happen. Certainly infection. But overall, oh, the other thing is they need to have ruptured membranes. So that's kind of the number one key is that membranes need to be ruptured in order for us to use any of these internal monitors.
Can I ask a really dumb question?
No questions dumb if you don't know the answer.
So why would it be contraindicated with vaginal bleeding?
Okay, that question's dumb. No, I'm just kidding. I just had to say that. That's not dumb at all, actually. It's contraindicated if there's bleeding, vaginal bleeding.
Yeah.
We already are very concerned about the placenta. Is the placenta separating? Is the placenta really low near the cervix? There's something going on with the placenta. So I'm not going to stick a catheter up there and aggravate that placenta any more than it's already on edge.
So then you would use other ways to figure out what's going on with the baby then?
If there were other ways, then we would, or we would sit and watch and yeah.
Okay, all right.
Contraindicated because
Something's already wrong. You don't
something's already amiss.
Okay.
And any introduction of something else into the area
Yeah.
might be the last straw for a
Okay.
placenta.
Okay.
Yeah, that's a very
I
good
just-
question,
I didn't know
actually.
'cause I figured
I was
that-
joking about, because I said no question's stupid. No, actually, I was clearly joking. That's a very good question. And that brings you to the disadvantages and the risks. You're poking something up into a uterus.
Right.
It could poke through that already fragile placenta.
Yeah.
It can poke through a uterus. It can poke, we gotta look at risks and benefits. And if we can not do it and kind of get by, then we will. Mhm. Did I mention before that cervical dilation is the single most accurate measure of
You did.
progression of labor? Yeah, probably something you should remember. Progress of labor really depends on all those P's that I talked about before. The passage, the passenger, the powers, right? All of those P's have to kind of be in alignment and working ideally in order for labor to progress and be successful. It's up to us as the nurses to kind of coordinate and utilize all those P's and do what we can to protect the good in it all and make it happen, right? We have to keep in mind, any cultural expectations and comforts. We need to include the whole family, if there's family there, to support them in the process as well. They can work with you as a team if they are included and informed on how they best can help, And we got to keep our patients safe. One of whom we can see, touch, and talk to. The other one can only talk to us through the fetal heart rate. So we're gonna feel that belly. We're gonna know where we're putting that fetal monitor. We're gonna watch the fetal heart rate. We're gonna find out did she break her water? Has she voided recently? We're going to check her vital signs, including temperature. We're going to take temperature on any labor patient every 4 hours, but every 1 to 2, depending on the facility, after rupture of membranes because of the increased risk of infection. We are going to assess the fetal heart rate and contraction pattern on the fetal monitor. We're going to let everyone know what we're doing, why we're doing it, what's going to come next, why we're doing that. Going to talk about comfort measures, keeping them comfortable. Certainly, depending on where they are in labor, will depend on what we can provide for them in terms of comfort. transition, basically you just have to like, I don't know, keep the patient in the room. Your job, I think, as a support person in the room becomes even more important during that intense time for a patient. That video was a humorous look at it, and sometimes it can be quite similar to that. But clearly that patient is that overwhelmed and behaving so outrageously, not by choice. And oftentimes, it's the first thing she does after the baby's born. Oh my gosh, I'm so sorry. Don't be sorry. Don't be sorry. I just knew you were close, so we're good. Everything's good. You know. I think people get so wrapped up in technology. Well, the monitor says this. They should precept new nurses all the time. Surprise, surprise. Well, the monitor is always showing this. I said, what are your hands showing you? What? Have you laid your hands on the woman's belly? How strong do the contractions feel to your fingers? Is the belly soft between contractions? Lay your hands on the patient. Palpate what's going on. I think it's important. In fact, I still, even though there's other technologically sound things to do too, I always write in my charting, contractions moderate to palpation, let's say. Abdomen soft between contractions. So that's telling the lawyers, right? That's what documentation is about. That I checked and that her abdomen was soft. Remember I talked about the optimal oxygenation happens when the uterus is relaxed. So I want to make sure her uterus relaxes. That's something, kind of simple, but and people might be doing that, but make sure you document that you've done that. So there's a lot of laying of hands that some probably newer nurses that are probably more reliant on technology. I'm not saying technology is bad at all, but we forget that babies were born for many, many years before any of this technology came along. So we got to fall back on the humanness of the process a bit. And it's, I think, quite prudent to back up technology with our 5 senses. Back labor. Talk about touch. Back labor is tough, right? Back labor is, who has had back labor? Anyone here? A little bit. I know there are some people, some other people talked a little bit about it. I had it. It was horrid. There was constant pain that just got worse during contraction. And no matter how much I tried to relax the rest of my body, during a contraction, my legs would stiffen up and just shake, and I couldn't do anything to stop it. You should see me for that hour, all crunched up into a ball. That was fun, trying to do that. And it's still not bitter. Yeah, I couldn't do that because I was being induced, and they needed to continuously monitor me. And hands and knees, they couldn't monitor me. So my husband was as tired as me, I imagine. Well, maybe not quite. But for 27 plus hours, he, with all his might, pressed on my lower back and didn't get any break either. I remember once, as it should be, no. I remember once, I couldn't do anything about it, but I must have, I'm like, sleep me, can you sleep me? Like, I was asking for any medications, like, I don't care, just sleep me. Anyways, he thought I was sleeping. And I remember, he got all the way to the bathroom. Poor guy needed to go to the bathroom. He was like, putting his hand on the handle of the bathroom, and then here comes the contraction. I'm like, I need you. He's like, right on back. The poor guy. I have to say, he was a very good labor coach. Mm-hmm. And maybe at this point, I'll give you his number. If everyone could just give him a call, preferably between the hours of midnight and say like 5 a.m. Each one of you individually, if you could just call and thank him for being such a good labor coach. You don't have to give the name or anything like that. Just say, I heard you were good, and then hang up. Thanks so much. He'll appreciate the feedback. Anyways,
What is the tennis balls and sock? I keep imagining like beat movements.
yeah, rolling,
Oh,
yeah. Mm-hmm. Wha-pow.
I know, right? Like
Shika-ching.
prison shame.
Yeah. You might do that to the anesthesiologist. You can't get your epidural in. I'm just kidding. All of which is perfectly reasonable. Actually, I have to stop this and start over.